Some people think that sleeping 4 hours is okay, and it's not. Or you'll get things like, I sleep great, I fall asleep really fast, but I wake up 6 or 7 times a night. Treat what you find and don't be attached to your hypothesis. The more you can be adaptable and fluid with your hands and fluid with your thought process, I think the more successful you're going to be. The emotional component that comes with change is a real thing. And so we talk a lot about when people are looking for the pain and it's not there.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim-Pettis.
We made it and we're here and we get to, so tell me.
Oh, yeah, I have to send out the welcome letter to the folks from Costa Rica, but I have the pictures, and it is, even especially Wendy and Danielle, even Kevin slept, and Wendy said it feels so different. And the class was, there were three non-practitioners, one naturopathic chiropractic student in her third year from NCNM, 1 or 2 DCs, 4 or 5 physical therapists, maybe 1 massage therapist, 1 acupuncturist. Anyway, they all had, most of them had really good physical medicine skills. And after we left Rome, which was maybe 2 weeks before we came here, I was able to extend my right hip because of the work that Eduardo had done on my dura. And 3 days after we left Rome, the front of my right thigh began to burn and cramp. And then at some point, actually when we were in Chicago, the rec fem and the joint capsule got caught in the joint. And so I bought a cane in Chicago and some Tylenol. And then I got to the seminar and they spent like an hour working on me and I lost track. But somebody said there were four people and 5 machines working on me. And what happened was there was still a section of the dura adhered to the sacrum right next to the right SI joint. And so one of the PTs was a specialist in that. She moved that out. And then we found out that that rectus femoris and femoral plexus story that I tell, we took care of my left femoral plexus. We'd never treated my right one. So I didn't know, because I couldn't extend my hip anyway because of the dura. All of a sudden I could extend my hip. My glute wasn't firing.
Right.
And so they got that to fire. And all of the practicum, so they fixed that in 2 days. And all of the practicums were just amazing.
Great.
The supine lumbar one, in 30 years of teaching this, almost 30 years of teaching this, I've never in a course in the supine lumbar treated scarring in the appendix. And one of the PTs...
You treated mine in Kona.
Oh, that's right. Then these were the next 2. Because his was about 5 inches long, get to the end of the psoas, and you drop your hands down into the lower abdomen, and it was like, and the physical therapist said, I feel stiff. And I went, the only thing that was down there is the appendix. So
Right.
it was, I said, it can be 1 inch long or it can be 5 inches long.
Yeah.
Tracked it under the bladder and took out scarring in the appendix, scarring in the bladder. That was pretty fun. And then Anamaya, the food was irresistible. That was cool. And it's hard. This is, and Annamaya is in a similar transitional forest. So it's not a cloud rainforest and it's not lower forest, but it was a great class. We had a good time. And as we're already scheduled to go back next year.
Yes, I'm very excited about that.
Yeah.
I got some great pictures. I got some great stories. Like always, there's such an organic segue to something that I wanted to talk about is when you treat something, say a chronic condition, and let's just say Ehlers-Danlos, because it's at the top of my email list right now of patients that are writing in questions. A lot of times we sometimes expect the pathway to healing to be this nice linear curve where pain goes down and movement gets better and everybody goes on their way, but that's not always reality. And so to your point, what you're explaining with Eduardo treating you, some things will resurface or new pain will surface that you didn't necessarily think of. And sometimes patients can get really freaked out by it. All of a sudden you're treating somebody for low back pain and then their low back pain gets better, but then their knees start hurting. And for me, I'm like, yeah, that makes sense. And people are like, but I never had knee pain before. And I'm like, I understand that, but you had low back pain and you had pelvis pain. And this is getting better, but sometimes. So do you want to start adding in some stuff and we can, because I feel like when I look on Facebook and when I get emails, this is a very common theme.
Yeah. It's why we changed the theme of the course to teaching you to think.
Sure.
Okay, you had low back pain, so now your low back doesn't hurt. And in order to get your low back not to hurt, we treated your psoas. Well, that changed your pelvic mechanics, and your hip is attached to your pelvis. And your knee gets caught between your hip and your foot. So treating your knee is easy. And what we need to do is look at your hip, look at your foot. So let me watch you stand up and see what the arches on your 2 feet do. And that's interesting. On the knee, the side of the knee that hurts, your arch is flat and your ankle is rolled inwards. So what happens if we tape, because can't get orthotics in my office. So I'll tape the arch and get the foot into neutral, put the talus back where it belongs, work on the hip capsule, the adductors, check the femoral plexus. Have you ever had abdominal surgery? No, I had my appendix out when I was 12. Okay, that counts. And then, so you have to connect the dots in your own head.
Right.
So that you can connect them for the patient. And for the practitioners that are listening, the thing I can recommend is what you tell the patient. Number one, don't freak out. Don't say, oh, I'm so sorry about your knee. I didn't mean to hurt you. Don't even go there. What you say is, oh, that is so interesting. That really tells us the next thing to do is. So for goodness sakes, don't work on the low back again. You follow the chain down because you're going to have to figure it out as you go along.
And to me, like, again, to the patients that are listening and the practitioners, change is always good. And to your point, to what you just said, it helps tell the story, right? So if you have a pelvis that has been rotated or has a torsion or has an inflare or an outflare, women who have just given birth, it would be really nice to think that the pelvis can expand, we can have a baby and then it goes back to normal, but that's not quite how it is. So as you're taking apart scar tissue, as you're helping correct one area, there are little pieces in the chain that can start to have an opinion about, hey, I was in this position for 5 years and now I'm not, and I don't like it.
And it's why the treatment plan is twice a week for 4 to 6 weeks. Because if you do your job right on the first and second day, there are going to be compensations that are either no longer needed or the compensations that are in place now cause problems elsewhere.
For sure.
So that's just how it goes. And Yeah, we had, yeah,
Yeah. And the longer something has been held in a position, not the longer it's going to take to undo. That's not necessarily true, but you have to be, as a practitioner, ready for those little pieces to occur in the story and be ready for them and to approach them, like you said, not with panic. This is normal. This is to be expected. Nobody needs to freak
well,
out.
I'm not sure I wouldn't say this is to be expected. It's, oh, okay, this tells us what to do next. This
Sure.
is that these are connected. And we had an interesting thing happen, and that was I treated this lady's neck one day, and then a different practitioner, one without a lot of manual skills, treated her the next day. And he pressed too hard when we were doing scarring in the dura to get the RCP minor to let go at the base of the skull.
Mm-hmm.
And he finished the supine cervical practicum, and she got up and she said, my neck really hurts. And we were ready for a break anyway, or it was the end of the day. And I said, okay, lay down. And where she pointed to was actually puffy and swollen. And her pain level was like an 8. And there's a group gathered around me. And I said, only thing that does that is 18 and 62. And so it is a lesson to be learned. I told the practitioner, it's while you're sitting there, you run concussion and Vegas on yourself and get yourself calmed down, because of course he was upset. And I just ran 18 and the capillaries, 162,
Right.
until the pain dropped from an 8 to a 6. And then we did 18 and the arteries until it dropped from a 6 to a 5. And then did torn and broken in the connective tissue at the base of the skull. And actually torn, and if you think about what we're doing at the base of the skull, if you aren't feeling gently and moving gently, if you use too much force, you can abrade the dura. So we ran torn and broken and your favorite trauma on the dura, and that dropped her pain again. And then we went down, and when you're doing the supine cervical practicum, it's really easy to push up too hard. So the COC1, C1, C2, C3 facets were inflamed and irritated. And so we got those calmed down. And then I think the next night I treated her again, and she had a disc at 5/6. So that's the driver for all of this anyway, for all of the facet stuff anyway. And then I used my little adjusting tool and got COC1, C2, C3 moving. And during the whole period when I was treating the facets at the top, we had one machine just doing torn and broken in the disc annulus at 5/6 to do that. Then got her to do eccentric OA flexion, occiput and C1 flexion, and 5 degrees, 5 degrees, got her to use the muscles. And we had to do 40 and 89 to just quiet down that terror and all of that. So it'll be fun.
Yeah, the emotional component that comes with change is a real thing. And so we talk a lot about when people are looking for the pain and it's not there. But
Right.
sometimes, like you said, sometimes the treatment takes on a different turn and people do have pain or they do have a irritation to the area, or it's not as better as they thought, or something else happens. And so that emotional component to it is, it's just like having an acute injury. You have to quiet that nervous system down, take the emotional charge out of the equation first, and then reevaluate and reassess.
And all these times when I've been saying, oh, I just treat 40 and 89 instead of using the 970s, I got a lesson in that this time.
Yeah.
When there was a group treating the supine lumbar or the visceral adhesions. And I can't remember, they ran a few of the 970s, but they ran, what was it? It was the patient who was injured in France and had the closest hospital went
Oh, in
over to,
Switzerland.
did we already tell this?
Yeah, Switzerland, I think, was the name of the, yeah, I think.
Anyway, so they left her in the
Yeah.
ambulance while they went and got coffee. And how
The
did that
abandonment.
feel? Abandonment. And she said, my whole world just changed. And it's very good.
Yeah.
Yeah.
It's like I said, the more we talk about it's less motor output and more sensory input, that's not necessarily just with our hands. It's listening for the story. My dad always said, you have 2 ears and 1 mouth for a reason.
Dad.
But it's true. And when you start hearing the story, when you hear it one time, you're more prone to listen for those nuggets that patients will tell you about the history. And you can help put those pieces together. And that's why multiple machines is a thing, so that you can deal with the emotional component, the nervous system component, the vagus, whatever on one side, and then treat what you're physically, mechanically trying to do on the other side.
Yeah.
Yeah.
Oh, we had another one. I have to change. I change the slides a lot. Again, we get to when you do scarring in the ureter, scarring the kidney, sclerosis in the fat pad, there were 2 different patients where we got the lower, 3 ribs to move as you release sclerosis in the kidney fat pad, those moved. Then move your hands up and press on the ribs, and it was like a rock. Right. Didn't move. Well, have you had any history of asthma? Nope. No asthma. And there's something else. She didn't have any reason. But what she said was, my mother was anesthetized when I was born. I've never been able to breathe up here. This never moved. What if when they pulled, it was a vaginal birth, what if they grabbed her head and just pulled? That's the biggest traction injury. So we treated scarring in the vagus all around under her jaw, down her neck, and scarring in the pleura, which is in the advanced, and just press on the ribs to release the pleura and get it to move, but then scarring in the vagus all the way down. So you run scarring in the vagus with one contact around the neck and the other contact down below the xiphoid, like in the upper abdomen.
Right.
And have her take a breath in and then make her hold her stomach down and breathe with her ribs and do scarring in the bronchi, scarring in the esophagus, scarring in the vagus. Take another deep breath in. She said, I didn't know I couldn't do that. Right. So that's been since birth. And I didn't find out that the ribs didn't move until we got the kidney free. And then you reach up and see, these move and these don't. What? Okay.
Yeah.
Treat what you find.
Treat what you find, and don't be attached to your hypothesis. The more you can be adaptable and fluid with your hands and fluid with your thought process, I think the more successful you're going to be. I have a practice at night. I look at my calendar the next morning to see what my day looks like. I see who's on the list, and I just jot down some ideas that I would like to try or what I think we should progress our exercises for. And I used to get so stuck on my list, and I have to just remind myself, this is just an idea, and we have to treat the individual that walks in the door and what they're presenting with, whether it's their mood, their physical findings. So ideas are just that. They're just ideas that you have, and then you have to just treat what you find.
Yeah, you have to what you find. And you're going to find something different almost every time.
For sure. And like I said, we never want people to be the same. I would rather have something come in an 8 out of 10 in a different area than be like, yeah, I didn't really notice anything different.
Yeah.
Let's get to one of the questions that we already have. It seems to be long. An LMT posted on Facebook received conflicting advice as to whether or not could treat women for various pain. Client responding to advice to avoid treating if person has epilepsy. Client says was diagnosed as a 16-year-old with arterial venous malformation, removed at 19. They're 65 now. Quote, I only have seizures occasionally early in the morning. Last one was recent, but I went 3 years without one coming off of all meds. Brother called at 4 a.m. and it shocked me, set me off. Other than that, I haven't even had auras. Then I would like to understand why doing frequencies is not a good idea for an epileptic. I sleep on a far heating pad every night to get more relief. I'm willing to try anything to improve my body and eliminate pain. Client history: epilepsy, angiomyolipoma on left kidney, microhematuria, blood, and urine. Would it be safe to treat pain with frequencies delivered via electrical FSM or PEMF? What are the concerns?
Either way, I don't understand where anybody gets the idea why doing frequencies is not a good idea for an epileptic. You're not supposed to run current through the brain. That's through the brain. And the only way to get through the brain is by putting your fingers in somebody's ears. So
Right.
let's not do that. But you can even run from the forehead to the neck and treat the C2 nerve root. And the current follows fascial planes. My first lesson in epilepsy was one of our practitioners back east someplace brought his wife to an exhibit I was doing at a medical meeting, maybe focused on pain, maybe. And she had an auto accident, I think, where she went through a windshield. And so she was having grand mal seizures, then sleeping for 3 days. She'd be awake for a half a day, have another grand mal seizure, sleep for 3 days. And she basically had 2 to 3 functional days a month. So he brought her and said, can we treat her? And I went, run the concussion protocol. These days, concussion in vagus. So the vagal nerve stimulators are approved for the treatment of actually the prevention of seizures. So there's that. And all I had back then, because it was 2009 that this meeting was, and we just ran the concussion protocol on her. And I think somebody even did a case report about it. She went from that, sleeping 3 hours, having a seizure every 3 days, to having the seizures went from grand mal to complex partial, and she'd sleep an hour and not have another one for 3 to 5 days. So she went from 3 functional days a month to 25 and reduced the kind of seizures she had. And that was just a concussion protocol. So if we had the vagus to it, it would probably help. All I can do is translate angiomyolipoma. That's on the left kidney. The microhematuria is, I'm assuming, related to whatever an angiomyolipoma is on the left kidney. And that's just, the kidney is a lace work. If you've ever been to Body Worlds, they take everything out of the kidney. They plasticize the capillaries and it looks like lace. And it's all little teeny capillaries. So whatever this lipoma thing is doing to a kidney is putting pressure on or doing something to make these capillaries bleed. And that's that, as long as it's micro and it's not frank blood. It's a whole separate issue. You can do 18 and 162 or stop bleeding in the capillary, and I don't know if it's going to work because I don't know what this pathology is doing to the left kidney. But there is what pain? Oh, would it be safe to treat pain with frequencies? I'd treat the seizures, but that's a no-brainer. Concussion protocol for migraines and seizures, concussion in Vegas. And then you can treat pain, you can treat stop bleeding in the kidney, but the kidney business and the blood in the urine is handled by a urologist, especially if you're a massage therapist.
I heard a rumor that a different FSM device had a warning on it to say, do not treat various conditions such as epilepsy. So perhaps maybe that was where the conflicting.
It's because,
yeah, I don't know.
yeah, that is probably the little booklet that comes with a custom care and a precision care. It's required by the FDA. As I say in every class, the devices are approved in the category of TENS devices. They use 1,000 times less current than TENS, and they're not actually TENS. They were approved in the category of TENS because the FDA in 1971 said if we approve them or put them in the category of TENS devices, then it's $50,000 for your 510K. If we have to create a whole new category, then it's $250,000, which was actual money in 1971. And so they said, okay, we'll be a TENS. So the manufacturer is obliged to put that booklet in. But there's a reason I go through those 2 slides twice, once in the core and once in the equipment practicum, and probably once in the practicum. So it helps if you act. Now I'm sounding like Dr. Mom. Helps if you actually read the slides. They're not TENS units, and FSM has extra contraindications. Some of the contraindications that apply to TENS don't apply to FSM at all,
Right.
So we don't run current through the brain just in case. And I do mention that. It's like, just in case the patient has an undiagnosed seizure disorder, you don't want to run current through the brain. And FSM has additional contraindications or precautions based on what the frequencies do. So TENS devices, you can't put a TENS device through a pregnant uterus. FSM practitioners should be really clear that once a patient is known to be pregnant, you don't treat her for anything, because of all the
don't
things.
know.
The real reducing inflammation, we don't get to pick which prostaglandins we get to reduce.
Right.
There's that. And Suzanne, it's the same as pulse DMF. Sorry, same as pulse DMF. Where were we?
Prostaglandins.
Prostaglandins. There are certain prostaglandins that maintain a pregnancy. There are certain prostaglandins that rebuild blood vessel wall lining. And that's why Celebrex was taken off the market, because it blocked the prostaglandin that rebuilt the artery wall. And that's why ibuprofen is hard on the kidneys and makes your gut bleed. And people say ibuprofen's hard on the liver. No, it's not. Tylenol is hard on the liver. Ibuprofen is hard on blood vessels because it blocks the prostaglandin that rebuilds the inside of the blood vessel and the inside of the gut lining, especially the stomach and the small bowel. So frequencies have additional contraindications. It says don't run a TENS device through a pregnant uterus. Once a patient is known to be pregnant, don't treat her at all for anything, because if her endorphins go up after the fetus is about 8 to 9 weeks old, the brain is already folded, and there are parts of the brain that are setting thresholds for neurotransmitters that we know for sure that we can change, like endorphins. So we have no way of knowing if, for mom, there's this big spike of endorphins as her back pain, whatever, gets better. And for her, it lasts about 2 hours, but for that fetus, it could last a lifetime. And nothing gives them pleasure. That's not good. No. Yeah. So be calm, send the patient to urologist for the business with the kidney. You can stop bleeding in the capillaries and the kidney, and treat concussion in vagus and any pain she has for the seizures.
Good. I'm glad we clarified that, because
thank you for asking.
Yeah, I think it's important. Like, Facebook is a great resource, but like anything, social media, we can't always take everything like the gospel. So always consult with your slides or write us an email. So thank you for those questions.
And the challenge I have is I used to cruise Facebook at night before I went to sleep and act as a little policeman. And I just am not allowed to do that. I am not allowed to look at Facebook. I am not allowed to open my computer when I'm getting home from the clinic at 7 or 8 o'clock at night.
Yeah.
I'm just not allowed. So I trust there are some instructors, there's Tom Affleck, who monitor things before they go too far down the rabbit hole. But that one is, Susanna, if you can pass that along and put capital letters on it,
this was clarified on the podcast by Dr. McMakin herself.
And yeah, there you go.
Perfect. Speaking of clarifying certain things, one of you were talking about sleep. Now, my go-to gold standard, if I have somebody that's having trouble sleeping, is the concussion in vagus protocol. It's not the sleep protocol. And the sleep protocol is good, but I think the questions about why are you having trouble sleeping? It's not just, do you have trouble sleeping, or how's your sleep? Because you're going to get answers like, oh, it's okay. And some people think that sleeping 4 hours is okay, and it's not. Or you'll get things like, I sleep great. I fall asleep really fast, but I wake up 6 or 7 times a night. And then you have to keep at, is it from pain? No, it's my brain. I just keep thinking about all these things. So one of the other questions is it concussion in vagus versus the sleep protocol? And that really depends on those questions of why are they having trouble sleeping? Is it pain? Treat the pain first. I'll let you go. You're already putting up your hand a couple times.
No, it's like, you're right. If it's a pain, that's easy. But David Musnick did I think a whole lecture, and at least part of it was on sleep hygiene.
Yes.
It's, do you watch screens at night? What time do you stop watching television or your computer or whatever? And then the one that you mentioned, the reason my hand went up is I fall asleep okay, but I wake up with my mind racing 4 or 5, 6 times a night. Those people need a sleep study. That's because your mind just doesn't start racing in the middle of the night. You need to make sure that they don't have sleep apnea. That's
because something else is waking them up and then they start thinking about those other things. So
Well, when it's sleep apnea, you wake up with your sympathetic nervous system jacked. Like, oh my God, we're going to die. But you don't remember that part because now that you're awake, breathing. Oops.
yeah, that talk that Dr. Musnick gave a couple years ago, if people want to find it, it was great. It was all about sleep. And he had about 21 or 22 little nuggets on sleep hygiene that I had boiled down. I took my favorite 10 and I have it on a printout in my office because there's some very basic ones in there, like dimmer switches, turning the lights down. As we're having this podcast, we can see in the background, it's gradually getting darker and darker behind you. That is what our biology wants. We want to have light turn gradually into dark. We don't have that now, right? We have full spectrum lighting, and all of a sudden we're like, okay, nighttime, and then we're in darkness. And that we don't just fall asleep like that. And also, we shouldn't fall asleep like that. If your latency should be 4 minutes from the time you get into bed and commit to sleep to the time you actually sleep. We want to see about 4 minutes. If you're hitting the pillow and you're out in 30 seconds, we are overtired. That's not healthy either. And we could have episodes upon episodes on just sleep. But when I was thinking about all the common things that we get, so the pain changing, and then sleep patterns is another common one, or sleep protocols. What do we use? It's figure out why they're not falling asleep right away or what they're doing. Maybe it's a sleep hygiene thing. Maybe it's something really easy, but asking the questions, is it the pain that's keeping you up? Because then it doesn't matter about running the sleep protocol. We want to run nerve pain or disc or whatever is keeping them up. And then things like what I call in the athletic community, the purge pad, because a lot of my hockey players and football players don't want to journal or open up their diary. But for athletes and even busy people, they're going to bed or they're getting in bed thinking, okay, tomorrow I have to do this and this, or today I didn't get all of this done. If you have an app on your phone or pencil and a piece of paper beside your bed and just write down those important things that you have to do tomorrow, even the important things that you didn't do today, your subconscious doesn't discriminate or differentiate between what you have to do in that stress. You wrote it down and it's check, check. I don't have to think about that anymore. And now I can concentrate on sleeping. So there's that talk that Dr. Musnick gave, tons of holistic pearls of wisdom all about sleep.
Always. Yeah.
Yeah.
And it should be in the advanced compendium. So we put at least the slides.
Yeah.
And I think on the Buddy Plus, there is the videos are available of different advanced courses. And I'm not sure how you search them. I have the Buddy. I don't have the Buddy Plus. That's because I have them all on my computer. Thank you, Kevin.
Oh, there is a question here.
Oh,
went back and it was Tom that recommended avoiding. Oh, but don't have to announce it.
Whoops. Okay. It's Pulse TMF. The challenge with Pulse TMF is it's obvious, but the only complaint we've ever had about FSM, about the magnetic converter, somebody that put the pucks next to her head. And I thought, okay, don't do that.
And that's been pretty clear to not run anything through the head. So,
and then I'll just run that by Tom. He's an engineer. It's like, he's a really good FSM practitioner, but he's also an engineer. So I'll just do a little reminder. But thank you so much. Yeah. That's really helpful, Susanna. It's misinformation is almost worse than no information. I'd rather have people not know and have to go back and look at the core slides and have misinformation out there, because FSM is really helpful, and epilepsy, especially concussion in Vegas.
What would we do without concussion in Vegas? I don't know. Yeah, and the questions about people who have just taken the course and what machines do I buy? I couldn't operate without both. And I found myself when I was in Dublin talking about the pros and cons about both devices. I couldn't function without the precision care to be able to manipulate things at will and just change everything. But I also wouldn't be able to survive without the custom care to just have things programmed that I don't have to think about changing all the time.
Yeah.
There's
The basics are always on there: low back pain, neck pain, nerve pain, concussion in Vegas minus 94. And that's a thing.
Yeah.
And I have to go through the new custom care software and make sure that I included a version of the concussion in Vegas without 94. That way you don't have to go in and modify it for as you put it on the unit. Because in my office, we have got 3 units that are in my treatment room, plus all the precision cares. And there's 2 versions of concussion in Vegas, and one is concussion minus 94, because there's patients with vestibular injuries about 10 to 20%, about 10 to 20% react by getting dizzy, or they get a headache, or their neck muscles get tight, or whatever. Suzanne, it has another good question. What would make 94 and a 61-year-old with scoliosis feel more weight in her lumbars? I'm going to have to ask you, did you do a vestibular screen?
And we'll wait for that question to be answered.
No. Okay, so here's the thing. When you have a vestibular injury, your brain tightens up at your neck muscles and to give it more proprioception. So one of the patients that the patient that I had to work on her neck, because it had the one that I had to fix. She also had a vestibular injury. And we had one machine that just ran 40 and 44 to quiet the inner ear the whole time, so that I could get to the deeper structures that needed to be treated to get her pain down. And if you run 94 on somebody, and it makes the vestibular part of the brain more agitated in a patient with scoliosis, if you tighten up the neck muscles, the whole chain is going to tighten, because it's not a straight weight-bearing column. It's like a coil, and you just squish it. Right. And so do a vestibular screen, tuning fork in the middle of the forehead. I know are you a massage therapist? I forget. Anyway, tuning fork. Okay. Massage therapists are caught in a little bit of a bind. They can't make a diagnosis. They can't put a diagnosis in the chart, but they can do a physical exam. So tuning fork, and it lateralizes, and follow my finger with your eyes, and their eyes bounce, and you have them fill out a BIVSS. And that you're not making a diagnosis. It's not going to, no diagnosis is going to go in your chart, but that's why she feels more weight. Okay, wait. Is this the same patient? 61-year-old with scoliosis feel more weight in the lumbar. And then you said he left feeling really good, and 94 was not bad. They don't always get dizzy right away. So was more weight in the lumbar, was that uncomfortable? In a scoliosis patient, you'd think it would be. So
I'm gonna interject. My computer may die in the next few minutes. I grabbed it out of my briefcase without the cord, so we have 10 minutes. So if I disappear, you know why. But fingers crossed I make it the next few minutes.
Okay.
Just wanted to
warn 10 everybody. 11 minutes.
Yeah. Patient. Oh, she wrote, yes, same patient, not uncomfortable. So I guess more weight in the lumbar was a good thing. I wasn't sure if I understood what that meant, more weight in the lumbar. I took it as more like pressure.
Yeah, me too. I took it as a bad thing, or why would you mention it? The thing is, I guess the reason I'm glad you brought this up, Suzanne, is it's okay to do the exam.
Right.
If you're going to run concussion in Vegas on somebody that you're doing a massage on, if anybody that's going to run the concussion protocol has to at least do a basic vestibular, just even if all you do is fields of gaze and watch and find out if the eyes bounce, that's fine. Yeah. But more weight in the lumbar would be from the muscles tightening, from 94 and 94 would be my guess. And you can also try 40 and 44, quieting the inner ear, and watch what it does to the neck muscles, because there's some neck pain patients that you can't actually treat without 94 and without 40 and 44. It's pretty cool.
Yes. I do have to clear every now and again. I make a mistake. Yes, it's unfathomable, but I used to always say with the concussion protocol, if you have patients or clients that do not react to 94 the first time, then you're going to be fine. Until last year, it bit me in the butt. And I had an athlete that I had been seeing for years and years, always responded great to the concussion protocol. And then all of a sudden started sweating, sat up, color drained from his face. I feel terrible. I looked, and sure enough, it was about 4 minutes into the concussion protocol where 94 is running. And I'm like, okay, hang on, just pause the machine to take a couple deep breaths. Yeah, it's gone. He's like, what was that? I'm like, you are the exception to the rule. You're the new outlier. So now I tell people, and he is a hockey player, so could have easily had a vestibular injury in between one time and another. So it's important to keep asking, even though I had seen this person for years and years, and I knew he was a hockey player, and he normally tells me of what he thinks are concussions or times he was hit. The very nature of their sport is a lot of brain rattling around in skull. Just be mindful of it, that you need to have 2 copies of that protocol.
Yeah. And if you get somebody that gets in trouble, I would try 40 and 44 and 40 and 94 to quiet it down.
Yeah.
And I still don't know why 94 and 94 creates those side effects.
Okay, that was my next question. Do we have any other ideas about what it is?
No, it is a factoid.
It is a factoid.
And I asked like an advanced class one time, how many people have never seen a reaction to 94? Like a third or a half of the class raised their hand. It's really?
Yeah.
Okay. But we hear about it on the Facebook page routinely. It's, hey, I treated a patient on Monday, and the next day they had a headache and they were nauseous and they threw up and they thought they got the flu, but then the day after that, and all I did differently on Monday was run the concussion protocol. It's like those two things are connected.
And I haven't heard of anything happening the day after. For me, it was just 2 examples in real time, like the Keith Pine story that you tell, where the football players get sick and just don't throw up on my shoe and you'll be fine. Yeah. I'm not quite so aggressive and harsh. I still have blankets and pillows. And I'm a mom, so I want to tuck all my players in their little nest on my table. Yeah. But yeah, just so people know, it can happen during and it can happen afterwards. So just stuff to watch out for. Yeah.
Yeah. And that is the thing. It's like the first time I saw it, the patient said the next day, we saw her 5 days in a row. This patient said the next day, I feel nauseous. And I thought, we did a lot of muscle work yesterday, so it's probably just that. So I gave her some thing for detox, liver stuff.
Sure.
That didn't help. She came in the next day, said, I'm still nauseous. And we're treating her shoulder. By the way, when that horse kicked you on the shoulder, did he by any chance hit you on the head? Oh yeah, right back here. See that scar? Right behind her ear. It's okay. So I gave her a meclizine and it went away.
Yeah. So there's that. Before my computer, I have 1% left. Before I evaporate, and I'm close. We have 5 minutes left. Just talking about the advanced, the amazing schedule. We tend to be closing out the podcast with this because I want people to take advantage of all the early bird specials and booking their plane tickets early with all the Black Friday sales that there are and Cyber Monday sales. So this is my little like
And
PSA
the
to
hotel
book
rooms,
everything.
in the hotel rooms, we have a small hotel for a reason.
Yeah.
And truth to be told, I am rewriting the advance for the first time in 20 plus years. It's the only 4-day advance there's going to be, I think. It's 2027 is a 2-day advance again, plus the symposium. And then in 28, if all goes well, we can try another 4-day. That'd be fun. But this is the one we can count on.
Yeah.
And I have 2 weeks in December to rewrite it. And now I actually have a really good idea of what to put in it. That's that, because it's what I do in my head that I don't tell people about. So I've got to make it fair.
Yeah, that's right.
But
I think what I'm going to do, I'm going to sign off before this goes off and then it's hard to edit. So like
okay.
I'm down to 1%. If you have more questions, people that are listening live, feel free to put them on. Dr. McMakin can talk to you for 3 more minutes, but I'm going to leave before, like I said before, I go and I die. So
do you have any other burning questions or comments or things that we should put on the things to talk about in the next 3 minutes?
The biggest thing I wanted to keep talking about was just that pain can change and it's nothing to be frightened about. And coming from a patient who is frightened that the pain is changing or maybe increasing, sometimes that can just feel very heavy for both parties involved. And so that was my big topic today. I think we did a good job.
Yep.
But if there are other frequencies that you want to give to people that can help with that, maybe anxiety or nervous tension when the pain does change, I'll let you finish off with that maybe.
Okay.
All right. But I will see everybody next week.
See you next week. Hi. The nice thing about Costa Rica is it gets dark at 6 o'clock straight up all year long. So that's dark in Costa Rica at 6 o'clock. I guess the thing about pain that changes is it tells you something. It's information. It's what we do even in the circle. It's how science works. It's not good. It's not bad. It's information. And if, for example, you're working on abdominal adhesions and you forget to finish with 18 and 62, stop bleeding, or 18 and the capillaries, stop bleeding in the capillaries. And then as you're sitting there talking to the patient, she says, my abdomen really, this is uncomfortable. It's okay to say, I can fix that. How about if you lay down? Because when you do abdominal adhesions and scarring, capillaries are really tiny. It's a pretty good chance that you just nicked a capillary in the process of breaking up the scar tissue, maybe a little faster or deeper or harder than you should. And the one reassuring thing I hope I have for everybody is it's really not possible for you to make as many mistakes as I've made. It can't. I've warned you about all the big ones. And Debbie says, I tell my patients I've changed tissue placement during this treatment, so it has to find its new place and you will improve. Trust me. The other thing I'd add to that, Debbie, is we changed these tissues that we worked on, but in the body, everything is connected to everything. So when we change, for example, you get into somebody's armpit and you release the subscap and then you release the lat, The lat is an internal rotator of the arm. So now that the arm can abduct, and then you free up the lat along the side, the lat attaches to the low back fascia. So the patient is going to, especially if you only work on one shoulder, the patient, of course, John Sharkey would, and you would understand that. Debbie says, I'm a neuromuscular, an NMT, John Sharkey student, so I understand that. So if you work on the shoulder, the next symptom may be in the low back, especially if you only worked on one shoulder. So the question is, do you listen to the patient and work on the low back, or do you work on the other shoulder and make sure that the lat on that side is freed up so that the low back musculature is now symmetrical? And there's that. Speaking of NMT and John Sharkey is coming to the advanced. He gets 90 minutes to speak. John Ruskey's going to be there. Jay Shaw is lecturing. Kim and Dr. Reynolds are lecturing. It's really a stellar cast. Dr. Wood is coming. We have had, I'm giving away a lot of money this year, which is great. We've had 3 published papers, one just in the last week, published by a physical therapist in India. We have the scleroderma paper. We have Karen Perry published the breast density, or Karen Perry published another paper. I think it was the breast density paper. So and there is a surprise because the Ruth Johnston Award is usually only given at the symposium. And I'm giving one out this year to somebody that really doesn't expect it. So that's going to be fun. Now we're on making time. It's 3 minutes after. So have a good night and do good things. And I'll see you next week.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.